you getting me? Getting me okay? The panelists are getting me okay? No delays?
Yes.
Great, thank you. I'd like to call at least the webinar to order. Thank you all for joining us as we begin this webinar, part of the Health Act series. So KMA in collaboration with KNH and the University of Nairobi, supported by Kenya Dental Association, Pharmaceutical Society of Kenya, the National Nursing Association, and the Lens. And so today's session will be on the Digital Health Act. And so with us, we have a panel of, we'll call them eminent personalities ready to speak to this act. So far, I think our first speaker has not been able to join us yet, Dr. Brenda.
Yes, she'll be joining us shortly.
Okay, wonderful. Thank you. So when she joins us, then hopefully we will have her speak to part of what we're supposed to do. And so what we'll have today is we'll have introductions and then go through the legal process with regards to the regulations that are supposed to accompany it, the process from a parliamentary standpoint, and that will be led by Honorable Irene Mayaka, as you can see on your screen. And then we will have Dr. Ryan Nyotu from the Ministry of Health, who will speak to the Act, why the Act, what it means, and then we will have Mr. John Kiragu, who will speak to what the Act means to a healthcare provider and to the health ecosystem. And finally, Paul Jugona as a data protection specialist, speaking to what the Act means from a data protection standpoint. This should take on average 28 to 30 minutes. And then we will have a panel with Q&A where we will delve into pertinent details of the Act that then we would want the panel to explain. And then we will open it up to the general public to ask questions. So as a housekeeping rule, please send any questions through your Q&A at the bottom of your screen, and any general chats through the chat. So then we'll be able to track both of them. Dr. Brenda, can you let me know when Honorable Irene is able to join? But then without further ado, I would hand this over to Dr. Ryan. Sorry, Dr. Ryan, now you're on the spot to take us through in 7 minutes what the Digital Health Act means from his standpoint, what and why. Dr. Ryan Nyotu works with the Ministry of Health Kenya. He's the head division for digital health under the Directorate of Digital Health, Informatics, Research, and Policy. Ryan, over to you.
Thank you very much, Dr. Kaka. Please confirm you can hear me clearly.
Getting you loud and clear.
Thank you very much. First of all, let me just greet all the participants. I can see we have around about 500 participants. It's a pleasure to speak to all the healthcare workers who've been able to log on today. I want to applaud KNH, I want to applaud KMA, and I want to applaud the Lens for putting together this forum to have this very important conversation about this specific act. So I will just get into it. My name is Dr. Ryan Nyotu. I'm a Kenyan, I'm a research scientist, I'm also a medical doctor. I'm also specialized in health innovation, which is about medical engineering field. that puts me at the intersection of the design, implementation, and evaluation of technologies within the healthcare sector. Currently have the honor and privilege to serve as the head of division for the first ever division in Kenya for the division of digital health, which is in the Directorate of Digital Health, Informatics, Research and Policy, a step that speaks greatly to the importance with which we are now viewing digital health in this country, which is basically what this act is our way to cement. For those of us who've been in the sector for digital health for a long time, we've seen its evolution, in the change of name. From the start, it's been called different things. It's also been housed under different vehicles as we've come in, but as its role has become more and more apparently important, it's now a standalone directorate, and now it's also moving and evolving into an agency just to handle the immense role it has. And what is the role of digital health in this sector in Kenya? In the new government, we've gained a lot of learnings from the previous attempts at UHC, and some lessons have come out very clearly. And one of them is you really have to move away from having this idea that universal healthcare can be achieved in silos, because bad outcomes in healthcare do not occur because of one individual thing. They work because of many things working in concert to cause disruption. And so solving the same problem takes a similar approach, looking at things together. And there are 4 things which have been identified as critical for digital. They have been identified as critical for digital health. I'll request to share my screen. So I'll be interrupting the current presentation. So there's some things which have to work there's some things which have to act in concert, and this is the health financing component of it. Has to work in concert with the commodity security, ensuring we have proper commodities, and also making sure that we're able to strengthen and utilize our human resources for healthcare efficiently. To be able to achieve this, and to be able to achieve it in the model that we are foreseeing coming, you require a lot of data. You require the data to move fast, to be at the point of utilization. We no longer rely on data for reporting. We need data for action. And that's why digital health has a very, very critical role in how all of the above functions are there. And just to take a step back and look at how we've arrived at this particular point, especially with the Digital Health Act. It began with the vision of MOH, which is to have a comprehensive integrated digital health information system. And this definition is pretty, again, I use the same word, comprehensive, in terms of how we look at it. Because comprehensive can be used to look at it from having a system which is end-to-end, but also you also look at it in terms of having a system which is backed by everything it requires, all the connectivity, all the infrastructure, all the legislation, and everything is in place before you are able to launch this. You're able to ensure all the delicate things are able to be balanced. And by delicate things, I mean you have to ensure that data is moving, and this data is moving very, 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 very seamlessly across the sector to the people who need it. But at the same time, you have to always make sure that you're in line with the data governance frameworks, which speak to 3 main areas. And this is the protection of the individual, and the protection of the individual and society and their data, and building trust in that data. The second one is the second principle of governance frameworks for data in healthcare in Kenya, looks at how can we make this data, which is identified as a national asset, how can we make it such that it's available and useful and valuable to everyone? How can we value add on the data that we have? And the last one is equity. No one gets left behind. So when you look at Kenya and the sector that we've had for a long time, one of the things we'll find is we've had a very how can I describe this? A very robust and very siloed implementation of tech. When you allow for digital technologies to be implemented within the structure and within Kenya without proper guidance, without proper regulation, and most importantly, without leadership from government, without proper leadership, government taking its role as a main central body within digital health, what you find is a system of siloed and duplicated and very spread out data collection mechanisms and systems running on the sector without them being interlinked with them. The graph on the screen is actually a quantitative diagram that shows implementation of tech in Kenya between the years 2001 and 2018, and this was a structure. So in this diagram, one of the things you notice is MOH is still quite solid at the center. So MOH is one which has a role to be able to achieve this. So this is a journey that the country is currently undertaking, and various documentations have been developed to develop the comprehensive highway. And to be able to do this, the aim is to see a patient all the way across the whole journey of a patient, from when you're in health-seeking behavior, when they're at home, as they come to seek care, and as they go back home in the last mile. We have to have mechanisms of how to track and be able to check at every step what is happening to the client. So this is the diagram, is the Kenya Digital Superhighway. This is this is adopted from a document which is called the Kenya Health Enterprise Architecture, which should be available soon for public consumption, which sets out how the architecture of the country is supposed to be. So you can see at the bottom we have the enabling environment, where we start with governance and regulation, something which is very, very critical, something which is very, very key, and has gotten us to this point with our current leadership being very ambitious in terms of wanting to implement the digital to digitize the country. You have to have the national infrastructure, which means you have to work with the Ministry of Interior to support in cybersecurity, to have the Ministry of ICT to support with the infrastructure, and any other partners within the country, with private and donors. And then now you come to the health information exchange and the core services. So in summary, the core services are what allow us to see a patient moving from one point or the other to home. For example, when the patient is at home, they'll be able to interact. We'll be able to interact with them. We'll be able to interact with them from
Dr.
several
Ryan,
places.
your voice is a bit muffled, so maybe just adjust your microphone.
Okay.
But go on.
Okay. Is it clear enough? Let me just switch off the mic to just the device. Please tell me if I'm clear enough.
Yeah. Yes, that's better.
Apologies. So how the Kenya National Health Information Exchange works is, you have a patient who is at home or a client who is at home and they want to seek services. As soon as they come to the facility, or as soon as they start engaging with the health system through platforms, we should be able to identify them. So here is where we have the Kenya Client Registry as one of the key registries within the Health Information Exchange. The Health Information Exchange is a bunch of registries working together with a bunch of services through an interoperability layer that allows for questions and queries to be routed to the correct registry to collect information, working together to provide the services. So this is the important part, and this is the one on which we build the other systems, the telemedicine systems, the other platforms, the other applications. For example, we have the EGs, the Chanjos, and the other applications that are going to be running, and the ones that are going to be developed moving forward. So the client registry is the one which enables us to identify that this is Ryan who's come to the facility. Ryan is a Kenyan, and this is the age, and it holds a lot of different metrics about that help us identify an individual uniquely, irrespective of which facility you go for. So this one is to move us away from having individual facility level IP numbers to now having a unique ID that is able to trigger and open up everything. So when they come to the facility, you identify them as a client registry, and it's linked to the Ministry of Interior IPRS system, which is an integrated population registry services. Then we have the Kenya Healthcare Worker Registry. This is the one which enables us to identify when this client has come and they've met the nurse or they've met the nurse or the clinical officer or the medical officer at the outpatient, or they've met any other healthcare worker. This is the one which enables us to identify that they were seen by this person and they are properly qualified to offer the service that they're offering at the place where they're offering it. This is also, then we move to the other registry, which is the facility registry. This is the one that enables us to identify that this facility is certified, is regulated and approved to offer the particular service, and where it is, and the different criteria, and how it's classified according to KEF. Then we have the community unit registry. This enables us to identify from which community unit the person has come in. This guides us in terms of accessing and reaching our clients in the health-seeking behavior bit, and also the last mile one as they go back home. Next, we have the National Health Terminology Service, or the National Health Data Dictionary. This is also a critical service which allows us to speak in one language. If you're being seen in Kenyatta and you're being treated for hypertension and you're referred to Kiambu level 5, the diagnosis should not be able to change. We should not have one person writing DB for diabetes and another writing diabetes type 2 for diabetes and writing high sugars. This one is the one which allows us to speak in one language. It determines the language we use for communicating within healthcare, and also determines the structure of how we communicate this. And then all of these engagements for the client are captured in our national shared health record. And then now this is where we're now able to feed, for example, the incentivized invoices the itemized invoices to the electronic claims management service. This is the one that allows for any person who's offering telemedicine to be uniquely identified as a healthcare worker, or we're able to identify this patient who's seen using this telemedicine platform, and this is what was done, and this is the care that was given, and it's in line with what the country says in terms of ensuring our quality. And then also this is how we're also able to track our logistics. So I will skip some of this. So in terms of planning, in terms of creating the enabling environment for digital health, we follow the 7 pillars of the digital health. So one of the critical components of this is, I've spoken about national governance. We do a lot of work in terms of setting the standards which we're going to use to communicate. This is through the data dictionary. We're also able to work on the infrastructure and also able to work and to build the workforce. But all this cannot be done if you are not anchored in law. One of the chaos we've had previously is having, especially as healthcare workers, is not being able to utilize political will properly and allowing it to come and change things. So as you're finding, we've done something for 5 years, and then in the next point, a new team comes in and everything is changing. So one of the ways to ensure that digital health remains bigger than individuals or bigger than anyone is to anchor it in law. And several laws have come to guide this conversation. And the first one, again, as I said, was a constitution which gave health as a right, and also which allows us to operationalize and set up the Health Act of 2017, which also is a first part where we see the Ministry of Health being mandated, or the Cabinet Secretary being mandated to set up the comprehensive integrated health information system, and the other regulations that are there. So quite a few regulations have been done to do this. We have the Health Act, we also have the DPO of 2019, but I'm sure someone also talk about this, which was very important, which has led us all the way now to the digital health. So one of the questions we always ask is why have a digital health bill? The president, and I've spoken about this in different ways. So it allows us to be able to keep up with the evolving landscape of the healthcare. Anyone who's read the Digital Health Act, it's looking deeply at how are you going to prepare for the coming future. We are now in the era where AI is evolving at a rate faster than we could ever have imagined. We have solutions coming in all manner of ways. We have healthcare being given to us through our watches, through different places, and all this is health data that is being collected, and none of it is coming back. So you need to set clear guidelines and regulations about how this technology is going to be adopted, how it's going to be managed, and who is going to safeguard the digital health information. At the moment, we have entities who come in, maybe they do some work for a few years, funding runs out, they close down, the system closes down, and we don't have any legal mechanisms of going to ensure that data doesn't disappear. Yet that data it doesn't belong to the government, doesn't belong to the organization, it belongs to the end user, the Kenyan, the client who gave that data. And someone has to come and take the role of protecting that data. And also it will also enable us to now really focus and put the Digital Health Act also really puts the end user at the center of the conversation. We keep talking about patient-centered care into digital health. The Health Act allows us to do this. And then also it allows us to streamline healthcare operations and leverage on real-time data. I don't know if I have time to go into the meat of the act, or we can do that a bit later. Or I also talk about the objectives. The objectives of the act are mostly to enable us to establish and maintain a comprehensive integrated health information system, to establish a digital framework, provide for privacy, confidentiality, and security of data, and also to develop standards for the provisions of health, telemedicine, e-learning, and any other thematic area of implementation within digital health, and also to establish a regulatory framework on e-waste management, which is something also something which is critical, because as these devices are being broken down, what happens to a device that has health data in it? What happens to it? Is it just to be discarded? What is the process of ensuring that data is protected even at the end of the life cycle of the waste that is going to be generated from these services? So I don't know. I'll take guidance from you, Dennis, on how far I can go with this in terms of the time we've been given.
You can hear me, and so I would propose then we will look at probably an outline when we look at the Q&A, so that then we have at least every speaker with a chance to talk about what it means. If that's okay with you.
Okay.
Thanks then, but thanks for that overview. That's pretty comprehensive. And I would like to hand this to the next speaker, and that's Mr. John Kirago. Mr. John is with the National Nurses Association of Kenya, but he's a public health specialist in health policy and economics research, and also an expert in healthcare financing. And what he will speak to is what then does the Digital Health Act mean to you as a doctor, you as a pharmacist, as a clinician, as a nurse, as a healthcare provider? What does the act mean and what does it portend as changes to you? Mr. John, are you able to take over?
Yes, Dennis, I can hear you.
Great.
Can you hear me?
Yes, I can hear you.
Okay.
Go on.
Thank you very much for the opportunity to make this presentation. So I have a PowerPoint presentation. I don't know if you'll project for me or I can project from my side.
Please project. You should be able to have projection rights.
Okay.
Thanks. You can see your screen, so maybe be slideshow.
Is it in slideshow?
Yes, it is. Thank you.
All right. Thank you very much, Dennis, for the opportunity to make a presentation. So in addition to the introduction about me, so I'm here as a representative of the National Nurses Association of Kenya. I'm also a clinician at Kenyatta National Hospital in the area of accident and emergency, and I support clinical research as well within the hospital. And I'm also a public health specialist with an interest in health policy and economics research. So today I'll present to you the Digital Healthcare Act 2023 and what the Act means to a healthcare provider. Just to give a bit of a background, I know Dr. Oyiro Nyotu has alluded to some of this. So we have the Kenya Health Policy that outlines the policy direction of the health sector, and it makes a projection with regard to the epidemiological transition of the triple burden of disease from communicable diseases, non-communicable, and injuries. And the projection shows that we will have an increase of 55% of NCD deaths and an increase of deaths from injuries and violence by 25% by the year 2030. So that is the projection of the Kenya Health Policy. And the policy outlines the obligations of the health sector in terms of the realization of the highest standard of health as a right, and also health as a means to economic development. And to be able to do this, the policy is supposed to be implemented with the following principles in mind: equity, participation, people-centered healthcare, efficiency in technology, social accountability, and the multi-sectoral collaboration. The goal of the policy are the same goals of the universal healthcare coverage, which are equity, responsiveness in care, and financial protection. And the means to be able to achieve these goals have been outlined in form of policy orientations, which are about 6, which are closely related to the building blocks of the healthcare system. And one of the policy orientation is health technology and medical products. And the policy states that the sector will apply technologies that are affordable, accessible, culturally acceptable, and feasible in trying to achieve some of these healthcare goals: life expectancy improvement by 16%, annual deaths reduction by 50%, and disability reduction or improvement by 25%. And this is supposed to happen equitably. Equitably, I mean, we are not working towards having life expectancy improve by 16% among the rich, and life expectancy, for example, worsen among the poorest of our population. Just to give a bit of another background with regard to digital health technologies adoption. So digital health has been shown and proven to enhance participatory care, person-centeredness, equity, cost savings, and efficiency in the healthcare system. So we have a recent report by the global, titled Global Digital Health Monitor report, which was based on a survey of 67 member states of the World Health Organization, which cites that less than 5% of health data is used in health decision-making, yet digital health could save up to 50% of healthcare costs. Previously, we have had deterrence to adoption of digital health technologies in Kenya, as very well captured by a recent study by Muiga and colleagues within the Kenyan healthcare system. Some of these deterrents were funding constraints, lack of users' confidence in digital health technologies, a mismatch between the workflow and the digital health technology implementation, leading to poor documentation in the electronic health records. Then lack of time for healthcare workers to effectively use the technology within very busy clinical workflows, leading to lack of usable EHR reports. Then another challenge pointed out in this study by Muiga et al. Was a top-down approach to implementation of the digital technologies, hence complicating the mismatch between the technology and the local needs. Other challenges are documented elsewhere about why we are not able to implement or to have optimal adoption of digital health technologies include digital illiteracy among healthcare providers. Then information silos, very well mentioned and explained by Dr. Nyotu, the first presenter. Information silos in the sense that hospitals are not willing to share the information with other hospitals. So they're not willing to share information externally, and that can deter inter-hospital data sharing. Then socioeconomic disadvantage, such as low income levels, education levels, geographical disadvantage, such as someone or a healthcare provider operating in an area with very poor coverage of the internet. So those are some of the challenges that Kenya has experienced before. And just to give an example of what could happen, let's say, for example, if you have you are trying to implement a digital health technology within a hospital setup. So I'll give a Malawian case study, and this was a case study based on a case study to improve quality, to improve digital literacy among 15 healthcare providers in Malawi. So the healthcare workers were trained on electronic medical records and how to fill them in when they are seeing patients. And in the course of this case study, this is what the authors observed, that there was literal transfer of skills from mobile devices to computers for healthcare workers. That even if healthcare workers owned a smartphone, that was not enough to make them digitally literate. Then they observed there were 3 levels of empowerment that was needed. Proficiency in the use of computers was supposed to be, I mean, if you were a healthcare worker was doing an administrative task, so they were not required, they were not very much pressured. So their speed of typing was not very relevant. But if a healthcare worker was at a service point, for example, the triage area, and they are supposed to use a computer, so those healthcare workers were supposed to be very fast and very fluent in terms of their skills. And then they observed the need for designing digital health technologies away from a top-down approach, and then the need for investment of training. So this is just an example, like a screenshot of the authors trying to explain what could happen. You have a digitally illiterate healthcare worker, and they're trying to fill in or to use a computer in a very busy clinical setup. So you'll have the healthcare workers trying to use a computer, then there will be a delay in the patient queue. I've highlighted what could happen down here. So you will have long waits on the queue, and that would discourage some of the patients, and they would start complaining. Some would start talking against the system. So the authors observed that if this happens, the healthcare workers would abandon the use of the EMR and postpone filling this electronic data later. And then there's another study that said healthcare workers, when they're confronted by a very busy clinical schedule, and they are still supposed to fill in the electronic health records, they can even faking data just to be able to make an entry and to proceed and to see the other patients. So that's an example of a challenge of a healthcare worker trying to adopt or trying to use this technology at service points. With that in mind, Kenya adopted the Digital Health Law, and that is the Digital Health Act 2023. And this act is supposed to establish the Digital Health Agency, support the adoption of the digital health technologies, regulate e-health as a recognized modality of care within the Kenyan healthcare system. And this is the overview of the bill, of the law. I'm sure we'll go through each and every article of the bill, of the law, as we are from the next presenters. But just an overview of the same. So the first part is the definition of terms. The second part, the Digital Health Agency, how it's supposed to be established. The third part is the Comprehensive Integrated Health Information System, the CIHIS. Then the health data governance, handling of ethical and privacy data issues, e-health service delivery, e-waste management, and finally, health tourism. So the question is, and the reason why I'm here, I'm going to give an overview of what does this act now mean to a healthcare provider. Healthcare providers are many. So we have nurses, we have doctors, we have clinic officers. Now we even have the community health promoters who are launched or who are given the go-ahead, to contribute towards the attainment of UHC. And these healthcare providers are serving at different levels of healthcare delivery, from level 1 to level 6 of the Kenyan healthcare system. We have some of these healthcare workers working at the county, under the county government, and other healthcare workers working under the national government. Taken together with other national laws, this act may have different opportunities as well as legal implications and mandates for different cadres of healthcare providers in Kenya. Now I will go clause by clause what each clause means for a healthcare provider. So the Digital Health Agency has been established under Part 2 and Part 3 of the law. And this Digital Health Act is supposed to advise the CEs on matters to do with digital health adoption within the country, supposed to carry out resource mobilization for health digitization and many other functions. So the main opportunity that as a healthcare provider I have seen under this particular clause is that we will have an opportunity for interfacility data sharing to improve referrals, continuity of care, and collaborative care. So this agency is also an opportunity for a focused resource mobilization for digital health within the Kenyan health systems. Then this agency is an opportunity to attract legislative tax support. So some of financing of this agency will be coming from the Treasury through the legislative appropriation. Then this agency is very important for the healthcare workers because it will serve as a very key agency in setting the standards for protection of the data subjects and personal health data and information. However, with this opportunity, of course, there are a few challenges that this particular clause presents. So one would be equity while trying to develop the standards for digital health. And by equity, we mean, for example, previous research has shown that uncritical adoption of digital health technologies can worsen pre-existing health inequities or create new ones. Let me give an example. If you come up with a digital health technology, for example, for antenatal care, and then so you have some of the women from very low socioeconomic backgrounds not being able to understand health data, such as their vital signs and the rest. But you have other group of women from, well-off parts of Kenya or from well-off families who are able to interpret this data. So there will be no equity in terms of antenatal care for women. So this will be a challenge. If we are going to implement digital health technologies, we'll have to put in measures, public health policies that are going to enhance equity. Then I have this quote that adoption of digital health policies and laws and the implementation without regard for social, structural, cultural, economic environments where the digital health policies are targeted can exacerbate inequalities of health. That is from Rich and colleagues. So this particular study talks about, previously we have had a lot of focus on downstream policy interventions or interventions that are going to support, hospitals. But we have had very few interventions intervening at the upstream levels of healthcare systems, such as trying to address the socioeconomic context of where some of these digital health technologies are going to be implemented. So if you let's say you are implementing a digital health technology in Kibera, the utilization might not be the same as the utilization of a particular digital health technology for someone, let's say, living in a high-end estate. So this is what they're talking about. So we need to think about how we can now shift investments, not just investing in downstreams like our hospitals, but we think about how we can invest digital health technologies within the communities. Then multi-sector collaboration to enhance upstream investments that enhance social determinants of health away from downstream investments. The second part, part 4 of the law, lays the framework for CIHIS, and this is a comprehensive integrated health information system. So the opportunities with a comprehensive health information system, this system is likely to support personalized and individualized care, support clinicians in terms of history taking. Some patients are not very well at giving us their previous medical histories, what drugs they were taking before, which hospitals they have been admitted before, whether they have had a transfusion or not. So if we have a comprehensive integrated health information system, so this will be very, very key for clinicians in terms of comprehensive initial medical evaluation. So this particular clause also sets the stage for, it will enhance opportunities for research in preventive healthcare. For example, if this particular database is able to link historical socio-demographic data with population level genomic data, this can enhance preventive measures on cancer, for example, breast cancer risk profile, and management can be picked up if we have socio-demographic risk factors, as well as genetic testing for something like BRCA genes. Then we'll have opportunities for data-driven resource allocation, budgeting, resource planning. Then this database will support emergency care, referral support through shared health plans. It will enhance follow-up and monitoring of patients beyond hospital setups. Then this particular database will be very, very essential for responding to pandemics. For example, let me see, if healthcare workers are not safe, widespread use of telehealth and will enhance remote care for some of our patients, and this will enhance safety of the healthcare providers. A few challenges with this particular clause of the law. Anticipated challenges includes there will be need to address information silos mentioned very well by Dr. Newto. Information silos, lack of willingness of hospitals to share data with other hospitals, or even hospitals do not have the incentives of sharing the data they have created with other hospitals. Then privacy requirements may deter adoption and exchange of data. Therefore, the policy objective that might follow after this particular law will have to target attaining interoperability and portability on one hand, and data privacy and security on the other hand. Then the other clause is part 5, which raised the platform for health data governance. Yes, can you hear me?
Yes, I'd like to pause you there, just because Honorable Irene has joined the call and she would not be able to stay with us to the end. And so I just wanted to give her a chance to make her remarks. Then we can proceed and figure out how to go on from there. Ladies and gentlemen, Honorable Irene Mayaka, member nominated MP, member of the Parliamentary Committee on Communication, Information and Innovation. She happens to be an accountant and certified public secretary by profession, and has previously worked as a banker in Kenya. So Honorable Irene, the floor is yours. Apologies, I know you had to do a number of things before you got here, but kindly take us through your part.
Hello?
Yes, we're getting you.
Hello, can you hear me?
Yes, I can hear you.
Thank you very much. And all right, thank you very much. And thank you for indulging me. Sorry, I logged in late. I had a few challenges. I was just listening to the previous presenter who was very comprehensive in terms of what the act actually entails. And so I will not go into it, but rather what I will go into is just sort of identifying and looking at what are the specifics we are talking about. Because first of all, especially considering the fact that I come from the Communication, Innovation and Information Committee, for me, anything relating to innovation and progression is most welcome. But also, we have to be alive to the challenges that we face as a country in our medical sector, and especially when it comes to that we are now being advised that we will have a system that will integrate the health system. And the concerns that I have, and I know most of you have, is in terms of the implementation process. Like how long is this going to take? By the time we have the health agency in place, how will they be able to then engage sector players like yourselves to make sure that they actually know what is going on? Because this phrase that we normally say, for ground between different, is actually very real. Because the act in itself is fantastic. It has gone step by step to actually explain what the intent is. But for me, the part that concerns me is the practicability of what the Act tells us that it's going to actually enable our hospitals, the medical service to be able to engage in. And one of the things that concerns me is especially on the data protection, because now, yes, we know anybody who deals with data, personal data for an individual, must have registered with the Data Protection Commission. But the question is, this is going to bring about a situation where there's joint responsibility in data protection. So, for example, if Hospital A has put in place a mechanism that completely has a seal-proof process of protecting data, how sure are you that when you transfer or share information with another facility, that they're going to do the same thing? Unless we have a joint data protection responsibility around it, this is going to be very difficult. And that is why another thing is that this particular act cannot work in isolation. That's what I also think. We still need a lot of regulations in place to just drive the process. So we're quite far from making this happen. The other thing is a pilot program. How is it going to be implemented? Are we going to have specific hospitals that will be engaged in the comprehensive integrated health information system for them to be able to first see, is this working? Secondly, just around that particular space is the we have to be in that comfort zone to ensure that this data and information
Honorable Irene, I think your connection is
another place
dropping.
It's dropping. Can you hear me now?
Yes, now it's back.
All right. So the other space I wanted to talk about is in terms of, so are we going to grandfather this other process? Is it going to be progressive, or are we just one day going to shut this the paper process and immediately plug into the digital process? Or what is going to be the grace period? So those are, I'm just putting out there some of the concerns that I feel, even coming from the medics space, that you also need to just engage in. The other thing is that nobody can work in isolation when it comes to this particular process. The health ministry, it can be the health ministry working alone, the medics, the hospitals. Everybody has to come into a space where we're able to look at what are the key issues and key concerns here. I know we really tried to have a debate to just express some of our fears in terms of implementation, but that unfortunately didn't go through. But for me, I just want to believe that this is a situation where even for us who are on the legislation side, should you feel like you still need our assistance in terms of if you try this and it doesn't work, or you feel like there's more that needs to be input, then ideally, I think you should be able to engage the health committee. I spoke to Dr. Nikal earlier, and he had mentioned if he had known about this earlier, he would have loved to join the webinar. But if you have other sessions, maybe you could also invite him, because unlike Dr. Nikal, I don't have any experience in the medical space, so I can't tell you I have experience in that. But I know he would be in a space to be able to connect the two, and also be in a space to actually advise you further. And he could be your point person in the health committee in terms of what you think are some of the ways and the implementation of this can be done. I'm sure we do have people even on this webinar who have had experiences from other countries, especially countries that have been able to implement this and it has worked. And we'd love to hear some of the things that they've been able to do. So peer engagement for me has to be a continuous exercise. and it can't be isolated by just one group. It has to be both the legislation side and the practitioners continuously speaking together. So that's what I wanted to give in terms of my feedback. I didn't want to get into each and every one of the clauses because the previous speaker, as I said, is doing a fantastic job in that. For me, what I just wanted to pick out were some of the issues I feel that would be a concern. I don't know about you. Maybe I could hear feedback from a few people or things that you feel as legislators we can come in to assist you. From the Communication, Information and Innovation Committee end, for us, our concern is if that digital system is actually going to work. Number two, who is going to be the custodian at the back end? Is the custodian going to be the Ministry of Health, or are there going to be situations where we have concurrent administrative rights given to specific people? So we also need to just know that space, what kind of users, end users and admins backend are we going to have, just to ensure that there's continuous engagement and there's continuous monitoring of this particular system when it eventually begins to take effect. So back to you.
Thank you so much, Honorable Irene. You've raised pertinent points that I was hoping then would come up in a few minutes. I hope you still have a few minutes to join the discussion. We have just one last speaker. John, I'd like to ask you to hold off on the presentation just so that we do the one last speaker and then we can open to a panel discussion.
Okay, that's okay.
And we'll have Paul Juguna. Paul is a data protection specialist, lead consultant with Vilasesi Resources. Paul, we'd just like to give you 5 to 7 minutes to give your input on where this act comes from, from a data protection standpoint, and then we can open up to a more detailed panel discussion where now we can start asking the questions, what makes sense, what doesn't, and, come up with something after that. So, Mr. Paul, over to you.
Good evening. Thank you so much, Dr. Okara and the team, for giving me this opportunity to speak just briefly on what I've experienced in the trenches as a data protection consultant. Just to give you an overview, the Data Protection Act gets its mandate from Article 31C and D of the Constitution, which talks very clearly about the rights to privacy of individual data. And there's been a lot of activities around this. And listening to previous presenters, I was actually impressed that privacy by design is entrenched in the Digital Health Act. But of course, how do we work around it? One thing I can tell you for free and for sure is that the Kenyan citizen now is getting very, very well informed on their data privacy. And within the last 10 months, the ODPC office has received more than 3,500 complaints of their data being misused. So when we now come to dealing with the health data, which obviously involves personal data, what are the limits? How do we deal with this? There is an issue of research regulations. At what length do you do things like limiting predictive analysis? You've gotten my data, you are doing predictive analysis, and you tell me I'm going to die. Because you've gotten access to sensitive data. So yeah, there needs to be some framework to guide this, because the bottom line is Article 31C and D is very clear, data privacy. And that's why now this Data Protection Act came to be, and it has a body, it has regulation. I'm happy to hear that it will be very important to come with regulations because there are quite a number of things governing it. In the trenches, while I'm assisting entities to do compliance, there is also conflicts. A and B are right. So what happens? I'll give you just two good examples. One revolves legal, the other one revolves research. There's a company that was doing research for employees within a company, and they submitted their results. We know how these results are. They are in data analytics, and most of the time you can't know the source. So they went to the researching company and said, can you give us the raw data? We want to get it. So I was consulted and I asked them, look at it this way. The purpose of you having collected this data was to get some analysis or to give some analysis. What you can do, ask as many variant analysis you want to understand what you want. But the minute you give raw data and promise that you won't disclose the idea of a
Hello, did we lose Paul? Hello, Mr. Paul? Looks like we lost him. Yes. Okay. Let's see whether he'll be able to get back. Probably. No, he's dropped off. Great. So when he comes back, we'll probably have time to pick up on where he had left. I want to circle back to John Kiragu. Mr. John, we had interrupted a deck you were doing. How many minutes did you have left on it? Do you think it's something we can finish in the next 2 to 3 minutes and start the panel discussion?
Exactly, yeah. I
Wonderful.
had about 3 to 4 slides here to finish.
Okay. Please take us through, then we can begin the panel discussion.
Okay, thank you. Yeah, so this is where we left off. I don't know if you can see my screen.
Yes, it's visible. Health data governance.
Yeah, data governance. So, data governance. So, the law talks about who is the custodian of data, and there are a few opportunities within this article in terms of the law enhances transparency for medical legal support. It enhances consistency, robust records on care to inform regulation by the government, and empowered patients, for example, can easily point out discrepancies in care and enhance participation. So the law gives patients the right of having a copy of their personal data. So that's why patients are being involved in their own healthcare. So the law also supports respectful, through this data governance, respectful and quality care for patients through increased provider transparency. So you can see which drug the patient was given in hospital A and for what condition, and which other drug the patient was given in another hospital. The challenge here, the previous presenters have alluded to who owns this data. And traditionally, we know records are the property of the hospital. Then who gets paid for the use of the data? So regulations around these concerns will be necessary. The other clause within the law talks about handling of ethical and privacy data issues. Opportunity here is enhanced informed decision-making for providers at the emergency care. The law stipulates under what circumstances access to data can be allowed. For example, in an emergency setting where a patient is likely to die or suffer an irreversible damage. So the law gives, the direction on how healthcare providers can access some of this data to save lives. So the challenge here will be how can hospitals and data controllers prevent internal and external malicious repurposing of data? For example, if a patient gives out their data within this system, how can we prevent this data getting in the hands of sales and marketers? And so this is a concern that will require a policy intervention, a legislative intervention, just to make sure that we have more controls on the data. Then the other challenge is, how can we raise confidence of the users on safety of their personal information with digital health technologies? The other part within the law is e-health service delivery. So the opportunity here is that now that e-health has been established under the law, so it will encourage entrepreneurship opportunities among healthcare providers to set up their own e-health clinics and the rest, enhance private practice and employment opportunities, and even enhanced innovative business models for healthcare providers. The challenge here still remains information silos. So the creators of data do not have the incentive to share this data with others. Then digital illiteracy among healthcare providers remains a very big challenge in terms of e-health service delivery. Then the other challenge is, like I mentioned at the beginning of my presentation, about the need to enhance social determinants of digital health utilization. Second last part is e-waste management. The law talks about e-waste management as a very important component of digital healthcare. So, for example, let me give an example here. Poor e-waste management has been cited to contribute to climate change, with 95 million tons of carbon having been released in 2019 from electronic and electrical wastes. So this is an opportunity I can see that whereby we are having a rationale for increased involvement and investment by the health sector and healthcare providers in climate change mitigation and environmental control. Lastly, health tourism. So the law sets, it gives a direction that health data can be shared across borders. I mean, if you have a patient seeking healthcare in India and they have their personal health information in Kenya, so this data can be shared with a hospital in India or any other place that the patient is seeking healthcare from. So this will support health tourism, given the data support, which may translate to more employment and new practice frontiers for healthcare providers in health tourism industry. So enhanced access to specialized consultation across border will be supported through cross-border data sharing, portability, and new patient pathways. So the challenge here remains information silos. So maybe Kenya is not willing to share its population health data with another country. So there will be security issues around data sharing. So the last challenge is we need to provide assurance and confidence in cross-border data sharing, security, and privacy for the users. In conclusion, the law presents a legal framework and opportunities for health providers to exploit digital technologies as a modality of care towards attainment of UHC, health system goals, SDGs, and climate change commitments. However, more policy directives and reviews and regulations would be needed to give direction on strategies to address some of the anticipated challenges such as information silos and privacy concerns. General, I think this is a very good legal framework for us to keep investing in digital health and towards the realization of our health system goals. So thank you very much. KMA,
thank you so much.
Participants, and the National Nurses Association of Kenya for the opportunity to make this presentation. Thank you.
Great. Thank you so much, John. That's been wonderfully curated. Looking at time, we only have a few minutes to go, and I want us to have a bit of a panel discussion. Then, welcome back, Paul. Sorry, we lost you, but then we decided to go on. And so I will open up this panel discussion and just lead with a number of questions. As a bare minimum, please remember, this is very important. One, we are all Kenyans. I assume so, right? And that means we all want the best for the country and for ourselves. So anybody who's speaking, no matter how critical they are, they want their best and they have the best intentions for whatever they are speaking to. So nobody wants this country to fail. So once you come from that mindset, then we can begin the discussion. So the Digital Health Act first, John has clearly spoken to what the parts are, but then he mentioned something called CIHIS, the Comprehensive Integrated Health Information System. That was going to be established. And I know Dr. Ryan had tried to speak to parts of it. Ryan, I would probably ask you, any more details on this CIHIS? Where will it be based? What will it look like? Just in a few sentences, because I imagine it has to be somewhere. So, and who is funding it? Do we have the money for it? Where are we getting the money from? Dr. Ryan.
Thank you, Dennis. That's a good question. And I think, as I answered quite a few of the other concerns that have come up. I want to thank the other participants for the input. And maybe just as I started, maybe I can augment something I think wasn't a bit clear, is from the previous presentation by Kiragu. And this is on who owns the data. It's very, very critical that this becomes very clear. The owner of the data is a user. It's me, it's you, it's a Kenyan who's the owner of the data. And the entire purpose of a lot of this work we're doing, a lot of the legislation, a lot of the system design and everything is to ensure that we're able to come back to this, what we're talking about governance principles for data governance framework, which I'm sure my deputy director, Dr. Joyce Wishwe, is very, very, very passionate about. It's about how do we add value to the data, how do we ensure that the patient gains value from their own data. For me, that's a very, very critical component. So what is this comprehensive integrated health management information system? This one you have to take a step back to go back to what has the health information system in Kenya look like. Are we saying that now we are creating a new thing? No, we are not. We've had HRIOs working in the system all along. We've had the HIS1, the HIS2, and the previous versions before it. And even before that, we still had health record information officers collecting this data manually. The system here we're talking about, and we're referring to it as an ecosystem. This is something that has been happening in the health sector. It's been working well. We've been able to push data. When we add the comprehensive and integrated is where now the tech comes in to allow us to take those business processes that have been happening within the sector and move them into the technological landscape. So when we ask the question, where will this be housed? We are talking about two different components. And one component we're speaking about is the health information system is us as healthcare workers. It's us when we write notes in the files. It's us when we see a client, when we get a prescription, when we get a sick leave. If all that is the information which is part of the system. The tech itself, however, where is it going to be housed? Is what we talk about in the Kenya Digital Superhighway. It's this bunch of registries. And to respond to one of the concerns that was raised by my honorable member in terms of implementation and how practical this is, one of the things that has been done is in defining exactly what the CIHIS is. where exactly does it sit? Which part comes first? Which part comes later? Which part can be done in phases? Which part can be done together? And which part is government meant to really put its effort and its resources into? And this is the part I described in the middle as the Kenya Digital Superhighway, the National Core Digital Health Services, which are the registries. And just note, in the diagram we have right now, this work is currently ongoing. It's been ongoing for some time. And to remind everyone that the Digital Health Act is not the start. It's not the end of a process. It's a part of the journey. It sits in somewhere in the early middle part of this implementation journey. Because even as we sit and we discuss here, we have a client registry that is working, that is already integrated with the IPRS system. We sit together with the people doing Huduma number and we discuss some of these concerns about how to uniquely identify this person. This server currently sits within MOH storage infrastructure, which will take a form of a hybrid model where we have a localized MOH data center and cloud, and also cloud services in line with the DPA. We already have a functioning. We already have a form of the Kenya Health Facility Registry. This one also sits within the MOH storage centers, which are data centers and cloud services that are funded and run through MOH funding mechanisms, which also has various options. We have direct funding from government, we have donor engagement, we have PPPs, we have all these things that are all run under the ministry and the watchful eye of the accounting officer within the ministry.
Okay.
The funding.
Okay. Thank you, Dr. Ryan. I'm trying to avoid yes. I think we've got the crux of what you said. So you've talked about the data is what we are generating as healthcare workers. Then the systems are what we already have in hospitals linked to what now MOH is going to set up. And you've spoken to registries, but then that also brings me to the next question, still within the Data Act, that then provides for what they're calling national and county health data banks. How different are those from what you've already spoken to? And if we are talking about, say, a county health data bank, how different is that from the registry? How different is that from the entire system you're speaking to? Maybe just speak to what the data banks are.
Thank you. If you look at that diagram, and at the bottom we have enabling environment, and then we have the national ICT infrastructure. National ICT infrastructure here is where we now talk about the enterprise infrastructure, the servers, the data centers, and the cloud. This is what you're referring to. So we'll have the systems running, we'll have the core systems running at the national level. But at facility level, we'll have the point of care systems. The best way to describe this is to use the example of UHC, which is already running and is being deployed to 110,000 CHPs across the country. The way UHC is running, for example, is we have the central instances which are running within the MOH data centers. But even as we move, it's better to move to a federated type of structure where we have the data banks and the data centers set up at the counties, because one county may have different requirements. One county may be using one HMIS, one HMIS in their facility to see patients, and all these have to come and consume the resources that are national. So at national level, we'll have the shared core services, but then also we'll have different data banks within the camp, and the data bank is just where the data is stored. These are like, the best way to imagine them, it's like very large hard disks that are being placed in different places to hold the data of all the people. So there is a clear demarcation if we are able to go into the scope of the superhighway in terms of what goes where and what comes where and what are the responsibilities of different parties in terms of this. Because the other thing to remember is this highway has been developed in concert with the stakeholders in Kenya, a country which has very, very, very rich expertise in informatics and digital health. Currently, the president of the entire informatics association of Africa comes from Kenya, and we have a lot of capacity even at the county levels. So this storage is going to happen there. So for UHC, we have the national instance, but then we also have 47 independent instances where we are also going to transfer the capacity centrally to the counties for them to be able to develop. So these solutions we're developing with design thinking at the core, with the end user at the core. What exactly does a county need? What are the needs of this county? We can't say all counties have the same needs, yet we have an urban and an ASAL, for example, counties. Each of them will have different needs. They'll have different systems. The point for us is the point of this entire highway is to allow different systems that are operating within the country to all speak one language through one standard, and that data to be available for everyone in the whole country in a way that is accessible. So the data banks at county level are meant that there we're not talking about the infrastructure level. How will the data be stored at different places, and who is in charge of that? For example, if a data bank goes down in a county, who is the custodian? Who is responsible for this data? How do we back up that? How we can back up that data from national and from different places? But to talk about data, the data banks are, just to summarize, it's storage. We are talking about storage and where the data will be stored, and this is the supporting infrastructure for the cities.
Okay, thanks a lot. I'd like to interrupt there. Honorable Irene, you had raised a number of points on whether this digital system would work, the custodian, the privacy, the changeover period. Maybe you can take them and we ask them directly now to Dr. Ryan. Maybe he might be able to provide a bit of insight. Are you still on the call?
Sure, thank you. Yes, I am. Thank you, Dr. Ryan. Dr. Ryan has actually answered a few of the concerns I had, like, for example, the question of who owns the data, which is very important. I see that the Kenya Digital Health Superhighway, what I want to know from Dr. Ryan is, are you in essence going to use the same superhighway that is being used by the ICT ministry? And what I mean by that is because I do know they have plans of extending the level of reachability, but it's not at 100% right now. So in essence, my concern is, what about those counties that are out of this reach at the moment? So what's going to happen to them? That for me would be one concern. The second concern is in the cybersecurity space. And I did raise this because I know, like, right now, the NC4, that's the National Council on Cybersecurity, is in the process of actually coming up with enhanced regulation in the cybersecurity space. And I just want to know if you've been able to be in a space where you're giving your insights, or that you have gotten any insights from them. The concern before, for me, it's where you're in a space where you lose data. Then what happens? And especially if you have completely migrated the health system from the physical aspect to the digital aspect. And finally, for me, is on, and this is just feedback to Dr. Ryan, is that because of what happened with the world coin, we do need as a country to have a sandbox solution. What I mean by sandbox is a technological solution that is able to detect if there are other issues or if there are new dynamics that you need to take into consideration, because we all acknowledge the fact that ICT is a very dynamic space. The system that you're using now is relevant, but 10 years from now, it might not be relevant. So what that means is that you then need to have a sandbox solution that enables you to sort of have a backup plan in case that system becomes obsolete and you need to get into the next system. So maybe just if Ryan could just address those particular concerns. Thank you.
Thank you very much, Shemiwa. I always love talking to leaders because they always have this view that is not siloed and looking at the whole country. Though I'll request that you please ask the first question again, even as I respond to the other two.
Ryan, Dr. Ryan, the questions were coming from on top of my mind. But the first one was, I think it was on the digital superhighway. And what I wanted to know is if you're using the same map out that the ICT ministry is using, because what I know from that map out is that it doesn't reach or every area of this country. So there are some areas that are a bit isolated because of reachability. And I just want to know then what happens to them. Will they be able to integrate into this system, or will they wait until that digital superhighway mapping happens? So what I just want to know is whether or not you're using the same map out that the Ministry of ICT is using.
Thank you very much. I'll answer the first question and the second question together. So for the sake of time, one of the things that we are very fortunate about in working in this government is that it's a one government approach. For example, as Maisha Namba is being rolled out, health is on the table. For us guys, as we were developing the Digital Health Act, Ministry of Interior was there, and this is where the cybersecurity bill that's currently being developed is under. So we are together in this conversation. We're leveraging a lot on resources. We're trying to not reinvent the wheel as much as possible and trying to see how to make this as cost effective as possible. So for the digital highway, for example, one, if you look at the constitution of the board of directors of the Digital Health Agency, which is an agency which is being set up to streamline workforce issues. For example, if you imagine how much resources I need to be able to deploy some of the systems from MOH, the schemes of service in MOH don't allow me to hire developers, don't allow me to hire design thinkers, don't allow me to hire cybersecurity experts don't allow the ministry to hire them into the ministry. So we have to have a method of just holding hands together and moving through this conversation. So that's one of the things we've had. So if you look at the constitution of the board of the agency, we have representation from the PS Interior, the PS Treasury, the PS ICT, the PS Treasury, and the PS for Health, to just ensure that we have this conversation today. So in terms of the highway, yes, we're using the same infrastructure. If for example, if I use an example of the recent launch of the smart primary care network that was launched during the Mashudari celebration and the celebration of and also as a marking of the UHC acts coming to life, you'll find that we were on the ground together, all of us. We had the interior teams there helping us with cybersecurity. We had ICTA and Ministry of ICT present to help us to push the fiber all the way to the level 2 and level 3 facilities. And we also have the private sector on board. So for some of the counties where we are not able to reach them, we have conversations with all the telcos in terms of how can we get this connectivity. We need this connectivity here, and these conversations are already happening. But once those two questions in terms of the cybersecurity and the first one, how are we working together, that one is being done in concert, and we are all on the table together. And this is not a task which is being done by the Ministry of Health. This is a task which is being done for the Kenyans who do not understand who do not actually see a disparity in government. When they look at government, they see all of us as one piece. I really like your question about the sandboxes and how we are going to do this. This is something we've put in a lot of work for the innovators in the sector, for the healthcare practitioners who are wondering, how do I plug into the digital health sector? We have in the implementation plan how UHC is being rolled out. It's being rolled out through PCNs. So we're going to have 315 PCNs spread out across the whole country, reaching the entire population. So what we've done as a digital health team is come and help hands with the primary healthcare team and through Dr. Salim and the rest, and we've been able to work together to launch the first smart PCN. So this smart PCN is a digitization, full digitization, moving away from paper, full, all the way from community through EHs, level 1, level 2, level 3, level 4, all of them being digitized for a population of 150,000 people, and we're doing one of them in every county. The purpose of this is to create a contextualized sandbox, an area where technology ideas who want to prove their concept, where if we need to test something, if we need to come and look at something, we come and see how something will work, we're able to plug into this. So if you go to Kericho County, Bureti Sub-County, you'll find an entire community health unit, an entire level 2, level 3 facilities who are already linked all the way up to the hub, which is Kapkatet Hospital. And this provides us with an area for us to do some of this, for us to really do some of these tests. And it's a testament of how fast and how practical the digital superhighway is. Because again, to say the digital superhighway is a component, the Kenya Digital Health Superhighway is a component of the digital superhighway. It is the manifestation of the digital highway within the health sector. So
okay, thanks, Dr. Ryan. I want to interrupt you there. Thanks for that. I wanted to bring on board a data protection specialist. Just before he was cut off, he was bringing out an aspect of predictive analysis, and maybe he has a question on that or a comment. Mr. Paul.
Yes, predictive analysis. Yes, this is by the way, information that comes out as a result of doing a certain issue. So how do you deal with this? I mean, you've done a research, you have my name, my details, and all the data you have. In the end, it points something is going to happen to me. What are you supposed to do? Are you supposed to tell me or not to tell me? So how the Act deals with this is transparency. Yeah. In the beginning, there has to be an understanding. We are doing this because we want to achieve X, Y, Z. And in the event this could happen, this is a likelihood. So once you inform the data subject, this kind of things, it becomes not as a surprise. And you also have mechanism of managing such shocks. That is the angle I was explaining before I was cut off. As an example, yes.
Thanks for that. Now back to you, Dr. Ryan, then based on this database you're doing, based on how we understand and previous experiences we've had, even among healthcare practitioners on the call on data privacy, quote unquote. I'm sure you must have received those SMSs from either where we suspect someone sold our data as even practitioners to the highest bidder somewhere. How do we ensure then that, are there mechanisms you've put in place? Are they things you can explain to us in the simplest manner to make sure that then my data is not used for anything I do not consent for? And are there mechanisms to even ensure me as a patient, my grandmother, understands what she's consenting or not consenting to with regards to her data?
Thank you very much, Dr. Dennis. You're doing a really amazing job in managing this panel and even this conversation, and it's showing that we need more time. And I think we're willing to engage more to be able to go into this, because our desire is for everyone to be able to be advocates of us for this particular system. Yes, we have thought about how that is going to happen, and this is through one of the registries, one of the most important registries in the entire core services, that the shared health services that are going to be implemented. And this is the National Shared Health Record. National Shared Health Record is what we're going to be calling the source of truth for patient engagement within the sector. If you're seen by a particular healthcare worker, if you're given a particular drug, if you're charged a particular price, all that is going to be logged. And the beauty about this, it will also allow us to log access. It will also allow us to implement access controls of role-based access controls and time-based access controls, and also geographical access controls. This means that if you're being seen at a facility and you're going to the outpatient, and you've come from the psychiatrist and you're going to the outpatient to be able to book your next clinic, the person at outpatient, because of the rules, should not be able to have access to your private health data at this time. And all this is being designed into it. But the most important part of this is one of the applications that's going to be running on top of the shared health record. And this is the patient portal. The patient portal is a tool through which the patient will have autonomy over their data within the system. If, for example, you're moving from one healthcare worker to the next, and the next healthcare worker wants to access their data, and maybe let's even assume it's not even to the next. Let's say your doctor is consulting a second doctor using your record. The patient portal is how you will be able to have autonomy and control in terms of who is able to access you. And the beauty of the shared health record is that we'll have a log. We'll be able to have a log of who accessed what at what time and what was done with that record. So that is a critical part which is there, and I can say that it's based off of one of the most important registries that we're going to have in our country. Thank you.
Thanks a lot. We are really out of time, but then just as a summary, I see you've spoken to the Digital Health Agency, and then we have the CH system, and you've spoken of health records at hospitals, and then county health, registries, and then county health data banks, and national health data bank, a registry somewhere in MOH, as a single source of truth. You've spoken to a sandbox. You've also spoken to a patient, then also being able to control their own data through a data portal, right? I'm trying to summarize and bring everything into one. So I would give everyone just 60 seconds or 30 seconds, sorry, to give their last remarks. What are their thoughts on this act? What are their thoughts on the future, both from a legal, healthcare standpoint, technical standpoint, and what they understand and what they hope aspire will happen next with regards to this Digital Health Act. So I'll begin with Honorable Irene. Thank you for staying with us through to the end. Just a last remark, 30 seconds.
Thank you very much, Daktari. And let me just take this opportunity to also thank you and the team that organized this webinar, because as Dr. Ryan rightly puts it, this is a journey. And for me, it's a journey that just doesn't need one sector, but all sector players need to be continuously involved. And my challenge to them from the ministry is that they need to continuously involve the key sector players in the health industry, because we all want what's best for our country. Even when we critique, we don't critique because we want something to fail. We critique because we believe that when we do so, then we can get the best out of everything. And actually believe that if this is done in the right way, then Kenya can actually become a peer leader in this particular sector. From my end, in terms of legislation, whatever support that you do need, if you do need to also engage any other experts from the legislation space, please do let me know. I'll be more than willing to participate. And yeah, let's just keep doing what we believe is best for our country and for all of us. Thank you very much for the invitation.
Grateful. Thank you. Healthcare workers, hope you've had that. We have a friend in Parliament, and so someone we can always reach out to discuss these aspects. John, over to you. Last remark.
Thank you very much, Denise. Thank you very much, my colleagues, the presenters, and all the participants in the webinar and the organizers. So my appeal to, for example, Honorable Mayaka and the Legislative Assembly is to support bottoms-up ways of implementing digital health technologies, because we have seen previously a top-down approach to just implementing a technology is where we have a mismatch between the technology and the users and the clinical workflow. Otherwise, I'm very happy, I'm very honored to have had a chance to make a presentation here, and I look forward to engage with you in future webinars. Thank you very much, everyone.
Thank you so much, Mr. Kiragu. We especially like your example with Malawi and the reality that just because you know how to WhatsApp doesn't mean you know how to type in health records. You know, it's very enlightening to hear that. Over to you, our data protection specialist, Mr. Paul.
Thank you very much. It's clear there wasn't enough time to cover as much as would have wanted. Thank you for the invitation. I've also learned quite a lot about the Act. My key takeaway and what I would like to just emphasize on is the issue of purpose limitation and data minimization is very, very important. There are some questions that were in Q&A. I tried to answer as much as I could. And there is especially one that relates a grandmother and data and all that. Purpose limitation will work that very well. And the fact that it's been clear that ownership of data is a Kenyan citizen, that is very, very important. And I would just urge the team doing this to also work together with the Office of the Data Protection Commissioner. Just work together, find out a way how this will work, because we don't want a situation as we saw in Huduma. Huduma number was thrown out because it missed just one thing. It didn't document the data privacy impact assessment. why is this data being collected? For what purpose? What security are being put in place? So on and so on. And then finally, grassroots awareness is very important. It's good for that bottom-up approach, the people at the bottom to really understand what you guys are talking about in English so that they can also assimilate and also help in running the whole show. Otherwise, you might find a situation where people are shying away, my data is being done, these things. Yeah, grassroots awareness. Otherwise, thank you very much. I really appreciate this
Thanks a
evening.
lot. And I know you've used big words. Thank you. Data minimization, purpose limitation. But guys, I hope you can Google. It's very important to understand what these terms mean.
But it's English.
Yeah. No, they're not assume everyone is an expert. Yeah. It's very important that everyone also starts understanding this. So the challenge healthcare workers know your rights, know your data rights, know what data terms mean. So thanks a lot. And finally, Dr. Ryan, I know we've put you on the hotspot today. Unfortunately, you're the only one here representing MOH. And so, yes, you've taken most of the slack from us. So any final comments?
Thank you very much, Dr. Kaka, and thank you very much for how you've handled the conversation. Thank you for how you've guided it. I think we've been able to pass the message to the teams. My takeaway will focus on our listeners. Most of the listeners today were healthcare workers. We've talked today a lot about data, and sometimes when we talk about data, it may feel like it's an abstract thing. So the way I like to look at it is by looking back at how the definition of digital health has evolved over time. One of the definitions I really like that is becoming more and more popular is that digital health is a way for us to translate our knowledge that we generate as we go through our day-to-day into models that allow us to convert it into value in terms of maybe publications, value into policy, and also value into commercial availability. I look forward to the day where I'll see young doctors collaborating with retired doctors to develop systems that are able to plug into the highway and offer value to the patients. So this is what we're trying to do. We're in the back end, we're working together with everyone together. I can say we've worked together a lot with Parliament, we've worked together with the different ministries, the DPA, the Office of Data Commissioner is one of our most prized resources that we're very happy we're implementing this. After that office has come into place, makes a lot of things easier. But the whole purpose of all this back-end work is to create an enabling environment that allows the Kenyan healthcare worker to be able to use their knowledge, the data they are generating, and give it and convert it into value that is able to be tangible for the other person who is not in the sector. The same way that I use my knowledge in a hospital and I'm able to get a patient good outcomes and you're able to get income. Digital health is a similar thing, and it requires to be protected. It requires to be supported. So we're very open to these conversations. So we really appreciate for Kenyatta and KMA and the Lens taking time to focus on this very important topic, because as our leader, as our Mheshimiwa Irina said, this is not a journey that can be walked alone. And the fact that we are starting this engagement together with the healthcare workers is very important for us, because you are our advocates. You are the people who are going to go to the ground and inform the client about their rights. You are the ones who are going to tell them about, yes, whatever I've done, you'll be able to see it on your portal. This is how you access your portal. So please join us, please support us, and please criticize us as much as you can, but also give us helping hands, give us solutions, give us ideas, and give us also your experiences. We acknowledge that capacity is here with us. So thank you very much, Dr. Kaka, and again, thank you very much for how you've handled the session. Thank you.
Wonderful. Thank you, Ryan. Thank you, everyone. We've had more than 800 people at some point attending. Thank you to KMA for working with us. Thank you to the Lens. The Lens has been the moderator for this event. The Lens is a collaborative platform bringing together policyholders, innovators, researchers, entrepreneurs, stakeholders. Our idea is then, how do we create thought-provoking sessions? How do we showcase either groundbreaking or disruptive work or anything innovative in the healthcare sector? So the Lens has been your host. My name is Dennis Okaka. Thank you all for being with us and wish you a good evening. Thank you. Bye.
Thank you.
Thank you.
Good.